Hi, I'm Robin Golden from the American Society on Aging, and I'm representing them, but I also work at Rush University Medical Center in Chicago. It's so good to see you all here today. What's been wonderful about the Eldercare Workforce Alliance is that we have not been disciplinary specific or divided, and I thank our leadership and Nancy and Steve for that. And Yet today, I think it's important that we are getting into some disciplinary explanations for the crowd, and I'm here to talk about geriatric social work, and I'm pleased to be doing that because I think it's often a very misunderstood profession, particularly by policy workers, people that can influence these things. So I'm so glad you're here today to hear what we have to say. So I'm going to talk about what the problem is, why it matters, how to solve it, and what will happen when we do solve it. And I want to just start with a brief timeline. If we look at what the National Institute on Aging, that they predicted in 1987 that there'd be a need for 60 to 70,000 geriatric social workers by 2020. However, we've gone down in the number of social work students specializing in aging. It's decreased since 1996 by 15.8%. NIA again confirmed the need in 2004, and it reinforces that we have less than 10% of that projection is available in the workforce right now. 10% of practitioners with a master's of social work and 8% with a bachelor's report they plan to retire in 2 years. And only 9% of a survey that the National Association of Social Workers did said that they had identified gerontology as their primary area of practice, and fewer than 5% were specifically trained in geriatric social work or gerontological competencies. So that's very critical as well. With the majority becoming the minority, and we're going to be seeing many more people of limited English-speaking elderly as well as minority populations, it's going to be even more complicated because our workforce is not very diverse on top of that. 17% of geriatric social workers report vacancies are common in their agencies, and 21% indicate vacancies are hard to fill. And a study, to only make matters worse, a study of social work compensation reported salaries for those certified in geriatrics are less than the median for all practitioners in the rest of the field of social work. Employment of social workers, we thought, was going to rise since 2006, and that it was going to be faster than other occupations. So there seems to be the demand, but again, the supply is lacking. And with 72 million Americans who are almost 65, we need almost twice the number of people. We need 45% more of the people to deal with almost twice the number of older adults. So what does it all mean? America's population is aging, we know that, but the geriatric workforce is not keeping up, particularly in social work. As a result, we face a growing population to serve with a shrinking workforce, and with very poor incentives to enter the field exacerbate the problem. And this isn't different than the rest of the disciplines and the direct care workforce that we're talking about today. So what makes older adults vulnerable? They are usually older adults, become frail fairly quickly. They need our support. Their families and caregivers need our support. And we can ensure the quality of care and efficiency to address these complex issues, to reduce overutilization. Most older people we know want to age in place. They don't necessarily want to move. We're critical in that role as social workers and other workforce folks to be able to do that. We're also available to maximize family caregivers' well-being and productivity, which is very critical. And our cultural competence, particularly when we're talking about a person-centered way of care, is a very critical one. So how do we help? We help by promoting mental health and psychosocial well-being, providing care coordination, interventions to empower older clients, to modify their environment, to navigate very complex resources and difficult silos of care. You saw the difference between the acute and the home and community side. They're huge. It's a huge gulf that people fall through. So we're there to do all that and very much to assess the older adult and their family caregivers' abilities and capabilities, which are critical when we're thinking about a strengths-based way of looking. We're not looking at people as how can we throw services at them to help them, but to really understand what they're capable of and what they're able to do and complement that. So this is usually a way to reduce resource utilization unnecessarily, not to overutilize. We provide care in a variety of settings, health care both in terms of acute, more and more in primary care, mental health, social service agencies, national, state, and city government, particularly the aging network, very much home and community-based service, private practitioner types as geriatric care managers. But I think what's most critical about social workers is, particularly geriatric social workers, is they cut across the medical and social models. There are multiple languages in both settings, and I think we've been a translational role very often to cut across those languages on behalf of older adults, caregivers, and providers to ensure that communication and accountability.